It is the second in our spring series for the Geriatric Education Center's healthcare lecture series. My name is Barbara Cochran. I'm the director of the DeTournier Center for Healthy Aging here in the School of Nursing. And today I'm also representing the Northwest Geriatric Education Center. Just wanted to give you a reminder to check in with your site coordinators if you haven't filled out a profile form. We use that information to convince our funding agency to keep supporting this series. And your site coordinator should also have information about continuing education contact hours. You can now register and pay for those online, so you don't have to deal with checks and credit card numbers being mailed and that kind of thing. So check in with your site coordinators. And today I'm very happy to introduce Dr. Manoj Menon. I pronounced it right? Yeah. He is a medical oncologist with the University of Washington and Fred Hutchinson Cancer Research Center. He has a research interest in prognostic factors related to cancer in resource-limited areas, with a particular interest in the significance of anemia among cancer patients. He attends on clinical service at Harborview Medical Center and also participates in efforts of the AIDS Malignancy Clinical Trials Consortium, which is great, and we're really pleased to have you here to talk about approach to anemias and more.
Thank you so much. Again, thank you for attending both virtually and in the classroom. And if you have any questions, feel free to interrupt me, and I'll answer the questions and take questions at the end of the discussion as well. So just one more piece of background. So most of our work in the group that I work in at the Fred Hutch is in Uganda, where we have a cancer institute. And in studies there, over probably between 60 and 70% of children under the age of 5 are anemic. So, and globally, probably 50% of children globally are anemic. And we'll talk about what that exactly means and some of the consequences of anemia. So during this lecture, we'll talk about the approach to anemia clinically and what that entails. And so we'll talk about normal hematopoiesis and erythropoiesis, the approach to anemia, and we'll talk about some cases. And then we'll have an evaluation of the opposite of anemia, when the red blood cells content is very high, or what's called polycythemia. So normal hematopoiesis is just the formation of the blood elements in the body, and it starts with the hematopoietic stem cell. The University of Washington and the Fred Hutchinson Cancer Research Center is particularly interested in stem cell biology, as really scientists here pioneered the use of stem cell transplantation for the treatment and cure of a host of malignant and non-malignant conditions. So a hematopoietic stem cell, which is the cell you see on the top, it is at this point undifferentiated. It can go into different types of cells. It can go into lymphoid cells, which you see in the green. It can go into myeloid cells, and it can go into erythroid cells. The lymphoid cells are what's responsible for innate or adaptive immunity, and I'm just going to and they go into our B cells and T cells for antibody production. Myeloid cells go into neutrophils, basophils, eosinophils, which also fight off infection through innate immunity, and erythroid cells. And erythroid cells are the ones responsible for the production of red blood cells. And this is the line that we're going to discuss today. Again, the hematopoietic stem cell is a cell that is undifferentiated, and it will produce these cells that are then distinct and will develop into red blood cells, and they will develop in either the bone marrow or the blood. So the bone marrow or the blood are the two places where we see the cells, but we think of the bone marrow as the factory of red blood cells. It's the place that produces the cellular elements in our blood, and in order to assess how the factory is working, we oftentimes will do a bone marrow biopsy. And you all will be very familiar with these because we can do them at the bedside, at the inpatient setting or the outpatient setting. And depending on patient preference, we do either local anesthesia to the area or conscious sedation, depending on the preference of the patient. And it entails, after the anesthetic is given and after a sterile field is produced, we insert this Jamshidi needle, which is a relatively long needle, into the iliac bone, typically in the posterior fashion, as is seen in this picture right here. Our bone marrow, as we become adults, really, although we have bone marrow in various parts of our bone, it's really the hip girdle and the sternum that are the two sites of active blood formation as an adult. In children, even the long bones are involved, but as an adult, it's really the sternum and the iliac crest. The sternum, as you can imagine, we do sometimes do bone marrow aspirates from that area, but there's less room for error when you're putting a needle into someone's sternum. But sometimes we have to do that. And this is a nice picture depicting the surface, the bone marrow, and the iliac bone itself. So once we insert the needle into the hip bone, or into the hip bone primarily, we obtain an aspirate smear, and the aspirate is the liquid portion of the bone marrow, and we make a slide, as is seen here on your right, and we get a piece of the bone. We get a small, probably 1 to 2 centimeter area of the bone, which we look under the microscope. And this allows us to look at the smear, this aspirate smear, and to assess whether or not all of the cellular elements are present. And it allows us to get a broader view in terms of the biopsy into what's available there. And so you'll see in this biopsy, for example, we see a lot of white cells and a lot of darker purplish cells. The white cells, just from this perspective, they're all fat cells. And we expect to have fat in the bone marrow. And one way to figure out if there's too little fat or too much fat is we really want the cellular elements to be roughly the percentage of 100 minus the patient's age. So as we age, we have less cellular elements and more fat replacement with fat. And that gives us some estimate if we received an adequate sample. Much easier than obtaining a bone marrow biopsy is the peripheral blood smear. And a peripheral blood smear allows us to categorize what we're looking at, the cellular elements. The red blood cells, which you see, the ones you see most predominantly here are all red blood cells. The small little specks, those are platelets. And these larger cells are white blood cells, and specifically these are neutrophils. When we characterize the red blood cells, we do this in a blood smear, and this is what's depicted on this slide right here. And really, it's just taking a drop of blood onto a slide and smearing it in a linear fashion to get that. You want to sort of make it look sort of like this, where there's not too thick of any area of blood. And then we look at the red blood cells specifically to see, and we characterize the size of the cells, the shape of the cells, and if they're all similar looking, to characterize different types of features. And we'll talk about each of those specifically. And then one other thing we look at is the reticulocytes. And reticulocytes are new blood cells, new red blood cells specifically. And it gives us a sense of how well the factory is working. If a patient has anemia, the normal response from the body would be to try to produce more blood. It senses, the body can sense that there's inadequate red blood cells, and in order to rejuvenate that population, it's producing new red blood cells, and the bone marrow is pushing them out into the peripheral blood. And this is what you see here. So this is actually, you see this bluish tint, and that's really RNA elements that you're seeing in that blood. It hasn't had a chance to fully mature. And typically we expect 1% of circulating red blood cells to be reticulocytes. So in an average person, there's probably 5 million red blood cells circulating, and so 1% plus or minus a little. So we expect the absolute reticulocyte count to be between 20,000 and 60,000 per microliter. And when we look at the red blood smear analysis, we both do a view of the peripheral blood smear, but oftentimes we're dependent on an automated machine to give us some parameters. And so we look at and we'll talk about each of these specific parameters later, but we look at the red blood cell number, the white blood cell number, and the white blood cell, as we showed in that diagram, consists of a variety of different types of cells, like neutrophils and lymphocytes, and the differential will tell us what percentage of all of the white blood cells are those different subsets. We look at the platelets, the hemoglobin, which is the amount of and the hemoglobin in grams per deciliter, the volume of the cells, or the MCV, and the reticulocyte count. And then based on some of these factors, we calculate other parameters that you also are familiar with, like the hematocrit, which is simply the number of red blood cells times the volume, and that gives us a percentage. And so when we define anemia, both in clinical practice and in public health practices, we use some common terms. And two of the terms that are often used are hematocrit and hemoglobin. The hematocrit is a percentage of the blood volume that's occupied by red blood cells. So if this is the total, if this is the total blood volume, you can see that this red blood cell component may be about 40% or 45%, and so that would be the hematocrit. And in a man, it's typically 38 to 50% is a normal hematocrit, and in women it's slightly lower. It's 36 to 45% as a normal. And we can talk about why there's a slight difference between men and women. And the hemoglobin is actually a direct measurement in grams per deciliter of this of the red blood cells. And for the definition of anemia from the World Health Organization, it also varies by men and women. And if there's less than 13 grams per deciliter for men or less than 12 for women, that's considered anemia. A rough calculation, if one is more familiar with using the hematocrit rather than hemoglobin, you either can multiply by 3 or divide by 3, and that gives you a rough estimate. So if the hematocrit is 39, the hemoglobin is about 13. So that gives us a ballpark estimate. And some places in some areas of the country and parts of the world prefer one or the other. But when you see a patient and you get the readout, you'll get both of these values. So when we approach anemia, we want to know a host of different factors. We want to know what the clinical history is. Are there things on the physical examination? And we want to do a laboratory assessment. And that laboratory assessment contains really 3 primary questions. One, are the red blood cells produced appropriately? And this is what we were talking about with the reticulocyte count. If the normal response to blood loss or a reduced amount of red blood cells is for the body to produce more of it and releases those reticulocytes, those new red blood cells, into the bloodstream. So we want to make sure that there's a response going on, that the, quote, factory is working okay. If there's not enough of the reticulocytes into the peripheral blood, we want to assess the size of the red blood cells. And then we also want to look at whether or not any other cells are decreased. Again, the bone marrow is the site for white blood cells, red blood cells, and platelets, so we want to see if those other sites are decreased as well. And we'll look at the peripheral smear. So the first thing we look at, and the easiest thing, is to look at the clinical history and the exam. So for a patient who's anemic, what kinds of symptoms or complaints do you think a patient would have who's anemic?
Shortness
blood, oxygen carrying capacity. Good. There's, in addition to pallor, what other, are there other physical findings that you could think of if someone was anemic? We can go over it. So shortness of breath, which was mentioned, palpitations, fatigue, lightheadedness or headache, chest pain, claudication, confusion, again, typically in the elderly, pallor, or jaundice. So we really mentioned all of these, very good. Sometimes if platelets are involved, we can have petechiae, which are those little spots that you see really in dependent areas of the body, primarily the lower extremities. And then depending on how chronic this is, you can have enlarged spleen or liver. And this picture is just showing some pallor in the conjunctiva. And then again, we want to do a laboratory assessment. And again, we want to see if the factory is working, are the red blood cells being produced appropriately, what's the size of the red blood cells, and again, if any other cell lines are decreased. So the first step, again, is are the red blood cells being produced appropriately? In the reticulocyte count, as we said, it tells us if the marrow is working. But we do have to correct it. So how we correct it is we take the percentage of reticulocytes and then we multiply it by the patient's hematocrit over a normal hematocrit. We typically use the normal hematocrit of 45. And the reason we do this is because a patient who has a lower hematocrit, their reticulocyte percentage should be increased compared to normal. In a normal person, it should be 1%, but if there's blood loss and their hematocrit is lower, you'd want that number to be increased. And we look at a number of about 3%, and we characterize that as if it's less than 3%, we consider that hypoproliferative, and if it's greater than 3%, we consider it hyperproliferative. And then in addition to the percentage, we also look at the absolute reticulocyte count, and the calculation is there. And this is what we described initially. The normal reticulocyte count is between 20,000 and 60,000. Again, that's 1% of the total red blood cells. But in a patient whose red blood cell is low, we'd want that number to be higher than 20 to 60,000. And so again, these are reticulocytes. You can see them. The smaller cells are red blood cells of various stages of maturity, and then these larger cells, slightly lighter in color with a bluish tint, those are reticulocytes. And you can tell just from this small slide that this is clearly more than 1% of the cells. So it typically takes 7 to 10 days for a full response to occur, that the bone marrow, it takes a little while for everything to get revved up and going. And we want the corrected reticulocyte count to be about 3% and the absolute reticulocyte count to be about 120,000. Again, normal would be 40 to 50,000, and we want that to be double that, or maybe even triple that if there's anemia. But in order for the bone marrow to work, you need the ingredients to allow it to work. And so you need a healthy marrow, and you need things that we're familiar with. You need iron, you need vitamin B12, you need folate, and you need a hormone, erythropoietin. It is the hormone that's responsible for the generation of red blood cells. And sometimes this is used, erythropoietin, both for therapeutic uses in patients who have anemia. Oftentimes, if their body is not producing adequate amounts of erythropoietin, we administer erythropoietin to them to stimulate their bone marrow. And then sometimes it's used for non-therapeutic uses. Sometimes there have been athletes who have been in trouble for trying to boost their red blood cells with the use of medications like erythropoietin. And then we want to, especially if if the response to the factory is not working, or a response to anemia by the factory is not working, we want to look at the size of the cells. And we characterize them by the mean volume of the cells, the mean cell volume or the mean corpuscle volume. And we really categorize it. If it's less than 80, it's we call it microcytosis, and if it's more than 100, we call it macrocytosis, and everything else in between is really normal. And it's a relatively easy way for us to differentiate between the two, because we know there are certain disorders, iron deficiency anemia being the most common, thalassemia being the second most common cause of, and anemia of chronic diseases causing a low MCV or microcytosis, and then the vitamin deficiencies, vitamin B12 and folate, typically cause a increased size of the red blood cells. You have to be a little careful, because if there's a mixed picture, you may have a normal MCV, even if for example, you have iron deficiency and folate deficiency. It may appear that the cells are normal size, but you actually have both deficiencies. So just a normal MCV doesn't exclude the possibility of one or the other. And then there's anemias where the reticulocyte count is very high, and that is really a stress response that the bone marrow is sensing that there's a lot of blood loss, we need to get this taken care of quickly. And the three most common reasons for that is hemolysis, so breaking down of the red blood cells, blood loss, provided you have enough of the ingredients, the folate, the iron, and the B12, or if the marrow is recovering from a recent insult, including chemotherapy. And then for hemolysis, there's certain testing that we want to do to rule out hemolysis, because anemia, iron deficiency anemia, is not necessarily a medical emergency. Hemolytic anemia can be a medical emergency. And in our field, obviously massive blood loss is a medical emergency, but hemolysis in particular, there are therapeutic things that we can do to benefit that. And so we look at the haptoglobin, and haptoglobin is just a protein that binds to hemoglobin. And so if hemoglobin is released through hemolysis, the haptoglobin will bind to it, and so we'll see a low haptoglobin, we'll see elevations in LDH and indirect bilirubin, and the peripheral blood smear, and I'll show you a picture of that, there's some characteristic findings. And then again, we want to look whether the other cell lines are decreased as well, such as the white blood cells, importantly, and platelets. And if those other ones are also decreased, there are things we want to think about, including vitamin B12 deficiency, folate deficiency, importantly myelodysplasia, which is sort of a pre-acute leukemia, liver disease, and then toxins. And certain infections as well. And then we'll look at the peripheral blood smear. So this is showing really normal size red blood cells, and they all look around the same size with a central pallor here. In this one, the cells are of different sizes, but there's a lot of small cells, small red blood cells here. These should be a little larger, and this is a microcytosis. These cells have, if you can see them, I'm not sure how well you can see them, they have like a little bullseye here, and these sometimes we call target cells. There's a host of different causes of target cells, and some include liver disease as a possibility. And then we also see this, oops, I'm sorry. So these are the target cells, the ones that look like bullseye, and then you have fragmented cells here. And those fragmented cells can be because of hemolysis, that it's just shearing off the cells. And here you have, this can be something wrong with the bone marrow. You see different, really abnormal sizes and shapes of these red blood cells. So the peripheral blood smear really gives us a nice clue to what's going on. This, it's hard to tell, but this first slide could also be larger red blood cells. what we typically look at, and there's not a good, these are platelets here, but you compare the size of the red blood cell to a lymphocyte. In this picture, there's not a lymphocyte, but that gives us the approximate diameter of what a red blood cell should be. So let's go over some cases. And please, feel free to interrupt me as we talk about these cases. And I'll ask some questions while we go over this. So this is a 55-year-old artist who presents to his primary care physician with generalized fatigue and muscle weakness. He also notes he craves ice. Physical exam reveals pale conjunctiva. And that, we showed that picture a few slides ago. And so looking at his labs, his hemoglobin is 6.8. His hematocrit, again, is roughly 3 times that. His MCV, or the size of the cells, is 68. His white blood cell count is normal. His platelet count is 490,000, and his reticulocyte count is 3%, and it's corrected here. So what do people note about these labs or his physical exam findings or his complaints? It's microcytic, and why do you say that?
MCV is low.
Great.
Platelets are high.
Platelets are high, good. And that's an important observation. So he feels fatigued, which is one of the complaints that one of you all mentioned before is characteristic of being anemic. He has pale conjunctiva. His hematocrit is quite low. It's at 21%, so roughly half of what a normal percentage would be. As was mentioned, he's microcytotic with an MCV of 68. His platelets are 490. And what do you think about his reticulocytes? It's low considering how what his hematocrit is. So again, they corrected it by the percentage of 3% multiplied by his hematocrit of 21 divided by a normal hematocrit of 45 and revealed a 1.4%. So this would be considered a hypoproliferative anemia. So how would you approach this case from here? Are there other things you'd want? So when we looked at that first slide with the MCV, it was low MCV, normal MCV, or high MCV. And so what were some of the things on the low MCV that was in the differential? Iron deficiency. So if you wanted to assess iron deficiency, what kinds of things would you want to do, both in terms of asking him or laboratory testing? Nutrition. Yep, you'd want to see what kinds of food he's eating. Excellent. So one of the answers was ferritin and transferrin and all sorts of those things. That's good. What other things are you concerned about for a man who's 55 who has a hematocrit of 21 and looks like he's iron deficient?
Could be bleeding, loss of
And where would be a common place for a man to bleed?
colon.
Yeah. So, really a patient with, and we don't talk about too much of this in these slides, but anyone, especially anyone over 50 who's a male who has an iron deficiency anemia, you have to think of colon cancer, and they should be screened appropriately for that. Good. So I think we don't talk about colonoscopies in these next slides, but we do get some of the labs. So again, it's iron deficiency anemia, anemia of chronic disease, thalassemia, and sideroblastic anemia are in the differential of microcytic with decreased red blood cell production given the low reticulocyte count when it's corrected. And again, microcytosis is due to either a deficiency in the heme or globin. And so we look at the smear. of this. There's a large amount of central pallor. They look a little, they don't look as dark as you would expect. And so we check an iron study. So the iron level is low, but iron by itself actually isn't a great test to assess for iron deficiency. It contributes to the whole picture, but by itself it's not very helpful. We look at the iron binding capacity, and this is 460, so it's high, which is consistent with iron deficiency. We look at a transferrin saturation, as was mentioned, and that's low, which also is consistent with iron deficiency. And we look at the ferritin, and the ferritin is quite low. The ferritin is really the storage of iron, and so this is quite low, and again, consistent with iron deficiency. And they're just commenting that the MCH also is low, and it makes it not a dark color, a light color. And so, as you all suspected, the diagnosis was iron deficiency anemia. Again, it's the most common cause of anemia globally. And so, iron deficiency anemia, even some of the physical exam findings can be helpful. Chlamydia, these indentations in the fingernails, I'm not sure if you can appreciate it that well, are characteristic of anemia. So is glossitis here, and then this, glossitis, and then this angular chiliosis. They're all consistent with a diagnosis of iron deficiency, although we wouldn't make a diagnosis based strictly on those physical exam findings. And then iron homeostasis, the body really does a nice job of regulating iron. And this really probably has to do with evolutionary factors. Too much iron or too little iron both have their own problems. And there are some, and it probably has to do with an infectious etiology as well. There are certain parasites that really thrive on iron. And so evolutionarily, there's been mechanisms that sort of titrate the amount of iron that we have in our body. So certain parasites, including malaria, they like a rich environment filled with iron as nourishment for the parasite. And so the body, again, has developed a nice way to regulate this. And we actually, menstruating women lose iron on a regular basis, but there's not really another mechanism that we're expelling iron from the body in much quantity. So we really develop, we sort of reabsorb iron from the old red blood cells that are releasing hemoglobin and from macrophages that are releasing hemoglobin. And we take in iron in our diet, and I think we talk about, oh, here it is. So heme iron, which is the iron form found in meat, is better absorbed than iron found in non-meat sources such as soybeans or falafel or some vegetables. And so we ingest maybe 20 milligrams of elemental iron, but only a small fraction of that is actually absorbed. And this is just a picture. There's two sides of this. It's probably better to show together. So this is our duodenal cell. So as we're ingesting the iron, it's coming in this direction, and these macrophages are digesting red blood cells and releasing iron. And these are really the two ways that we have iron in our plasma. And these, I'll just point out, this ferroportin is the transport mechanism that ferries sort of the iron into the plasma from the duodenal cells or from the macrophages. And again, the regulation of iron is really strictly controlled. And it was found not too long ago that really the regulator of iron is this protein called hepcidin. And so hepcidin is the principal regulator of iron. It's a 25 amino acid peptide produced in the liver in response to iron loading. And there's a lot of text on here, not so much is that relevant, but hepcidin, it increases in times of inflammation or in times of too much iron. And by doing so, it blocks this ferroportin. So it does not allow the iron to come into the plasma. And you can imagine the reason why that's the case is that in a setting of inflammation, the body may think there's a parasite or something going on. It doesn't want all that iron in the blood where the parasite can take advantage of that. So that's really what it does. Oh, and here's actually a nicer, so it blocks this, this transport mechanism that hepcidin does. So during times of inflammation, the hepcidin levels will go up and block ferroportin, and during times of iron deficiency, the hepcidin will be low, and the transfer of iron from the enterocyte and the macrophages will increase accordingly. So iron deficiency anemia, the stores are empty, and that was, we saw that with the ferritin being so low. Because of that, they make smaller cells. They don't have enough heme or globin, and it leads to anemia. Again, they're hyperchromic and microcytic with the MCV of less than 80. The platelet count is often elevated. The ferritin, which is a measure of the total body stores, is low. But by itself, it's very specific for the diagnosis of iron deficiency, but it's not very sensitive, about 60% sensitive and 99% specific. And again, serum iron by itself is not a reliable indicator of iron deficiency. So the total iron binding capacity will be increased, but it's also increased in other situations, such as with pregnancy or oral contraception. The iron saturation is decreased, which shows a low circulating amount of free iron. And it's not, again, it's not sensitive for iron deficiency anemia, but it's not specific, sorry, it's not specific. And we can treat these patients with a trial of oral iron if they, because it's a relatively easy thing to do. You can give it orally. Sometimes we give it parenterally as well, but we treat it with iron. And if there's no response, then sometimes we need a bone marrow biopsy. In anemia of chronic disease, which can also be manifested by a microcytosis, there's typically high hepcidin levels, as we discussed, low serum iron. Unlike iron deficiency, the TIBC, the binding capacity is low. We have a low or normal transferrin saturation, whereas in iron deficiency, it's increased. And again, the ferritin is increased or normal in anemia of chronic disease, but it's low in iron deficiency. And if you want to do a bone marrow, which is what we show in this picture here, you see the presence of these macrophages, these reticular endothelial macrophages, and they're stained with iron, suggesting that they're sort of engulfing the iron. Calculating the iron deficit. So in order to calculate how much you should eventually replete, you calculate the body weight times, you take 14, which is the normal hemoglobin, minus the patient's hemoglobin, multiplied by this factor 2.145. And so in this patient, when you calculate the iron deficit, it becomes 506 milligrams, and that's the amount needed to fill the stores. Now, in practice, we don't do this that often, but that is the way to calculate the iron deficit. And so there are some dietary factors that can affect the absorption, and this is why we advise patients to do certain things when they're taking iron. And one of those things is the acid content of the stomach. And so oftentimes we'll ask them to drink or take the iron while they're ingesting orange juice, for example. And we want them to otherwise not take other food. So iron should not be given with food and not with calcium supplements. It changes the pH of the environment, and should be given if the person is on antacids or proton pump inhibitors. It should be given 2 hours before those medications. And again, ascorbic acid increases the absorption. And again, hemoglobin from or iron from meat sources is absorbed about at 30% versus non-heme sources, it's about 10%. And again, we can give it the preparations orally or parentally. And then we typically will check in about a week or 2 weeks to see how they're responding. And based on that data, we figure out how long to treat. And sometimes, again, we do calculate the iron deficit to give us an idea on how long they're treating. The problem with iron is that it's not that easily, some people don't tolerate it that well. It really causes abdominal pain and cramping, constipation, and so it's not the favorite of most patients, especially the oral formulation. Anemia of chronic disease. The treatment for anemia of chronic disease is to treat the chronic disease if we can. Consider a trial of iron to see if it's responsive. Avoid medications that will harm the bone marrow, again the factory, and then consider injections if necessary. So this is this is like 20 years old now, but this is a sculpture of an artist took 9.5 pints of his own blood to create this during a 5-month period of time. It's a bit morbid. So the take-home points is iron deficiency is common. 30% of menstruating women are iron deficient, and globally, again, over 50% of children worldwide are iron deficient. It's characterized by microcytosis and hyperproliferation, and in a menstruating woman can be treated with a trial of iron supplementation. And again, hepcidin is the principal iron regulatory protein in the body. Any questions about that case? So it's most likely thought to be an acute phase reactant, and so sometimes there's just the response that we see with platelets. Any other questions?
Chronic runners, hemolysis,
Yeah.
is that something that you see? Is that
You don't see it that often, but you do see sort of exercise-induced hemolysis. And sometimes, oh, sorry. The question was sometimes in athletes, chronic long-distance runners, sometimes you see some hemolysis in patients. And we'll talk about a case actually of hemolytic anemia shortly. Oops. Okay, so our second case is a 41-year-old woman who was previously healthy, who presents with fatigue and easy bruising that has worsened over the past 8 months. Her past medical history is significant for gastric bypass surgery for obesity 1 year ago. And on exam, she's tachycardic, and on neurologic exam, she has mild loss of position and vibratory senses in both of her feet. Her hemoglobin is 6.5. Her hematocrit is roughly 3 times that at 24%. Her MCV is 120. Her white blood cell count is 2,000 with a low neutrophil count, and her platelet count is also decreased. So what are you all thinking? What's some of the features of this case? MCV is very high. There's a lot of clues in this case. So the MCV, whoops. The MCV is very high. What are some other clues in the history? Yeah, why is that? The gastric bypass surgery was mentioned as a clue. Why is that a clue?
Because of the
Yes, excellent. So that's a big clue. And someone also mentioned the lack of intrinsic factor, and we'll talk about pernicious anemia, which is the lack of intrinsic factor later. That's a good point. And on neurologic exam, she has a loss of position, and so proprioception and vibratory senses, and that can be seen with nutrient deficiencies as well. So great. So her reticulocyte count was 1.2%, so not great. In an absolute count of 40,000. Her folate level was normal. Her B12 level is low. Her TSH was normal, and her MMA, methylmalonic acid, was increased. So what do you all think here?
Nutrient deficiency.
Yeah, specifically which nutrient?
B12.
Yeah.
Probably B12.
B12. So this looks like a B12 deficiency. And so B12, we have to be careful differentiating B12 and folate deficiency because there are a lot of similarities between the two. B12 is found primarily in animal products, so that can be dairy, meat, fish, or eggs. So a person who is a vegan who doesn't have any animal products in their diet, you do have to be careful, and they often will have to supplement in order to have an adequate intake of B12. It's absorbed in the ileum. We have 3 to 5 years of stores of B12. So someone who becomes a vegan in 3 months or 6 months, they're not going to be B12 deficient. But if they're chronically without the use of animal products, they can. Again, as was noted in this patient, the MCV was high, patient was anemic, and the reticulocyte count was low. And it also can lead to pancytopenia, which was the case in this patient. Her white blood cell count was low, her platelet count was low. And it can lead to CNS or sensory deficiencies, which was the case in this patient. Folate is in vegetables. It's absorbed in the jejunum. We only have a few weeks of folate as stored. It can cause the same hematologic parameters, but it does not cause neurologic deficit. And so we check for both. And one thing to help differentiate the two is the use of methylmalonic acid, especially in a patient who is sort of equivocal. And this patient had really all the characteristics of B12 deficiency, and her B12 was less than 200, but it wasn't so drastic. It was like 160 something or whatever. Her folate level was adequate, and so they checked an MMA and a homocysteine level. And one way to differentiate the B12 and folate is the use of MMA, which would be normal in normal in folate, but low, increased in B12 because it's not being metabolized. Homocysteine is in both. And if there's pernicious anemia, as one of the colleagues remotely mentioned, they could have anti-intrinsic factor antibodies that could lead to that. So the treatment for both, as you can imagine, is to give them back the nutrients, either the B12. Typically, it's B12 injections initially, and you first do it daily and then weekly and then monthly injections of B12. And then you can, if there's no neurologic deficits, you can give oral B12. And folate, we typically give oral folate. And then we assess response, and we want to make sure their neurologic signs are improving, as is their hematologic parameters. But these are patients that we follow up pretty closely. So B12 deficiency is common in the elderly. Again, MMA increase in B12 deficiency, but not folate deficiency. We have to rule out pernicious anemia, which again is a lack of intrinsic factor in malabsorption states. We use parenteral B12 treatment with neurologic deficits. and it's important to follow these patients up because if they have long-standing peripheral neuropathy, we oftentimes can't reverse that. So you want to catch it early and treat. And then oral B12, we want to confirm that they're responding appropriately. And again, you wouldn't give oral medication if they're still having any kind of neurologic deficit.
What if they also have a diabetic situation where, you know, you'd have neuropathy due to maybe two different things? Or
So the question is, what would happen if the patient was diabetic in addition to having a deficiency, a B12 deficiency for the neuropathy?
how would you differentiate?
So you would treat, you know, diabetic neuropathy typically is not reversible. You would treat both. You know, you obviously would treat their diabetes. If their laboratory parameters were consistent with B12 deficiency, you would just treat. And if you see improvements in the B12 level, but still you see persistence, I mean, eventually you may not need to still give injections. You could, if you think they have diabetic neuropathy, you could go oral after a certain period of time. So case 3, this is a patient, 58-year-old woman with chest pain and dark urine. She has a past medical history of diabetes, hypertension, and Raynaud's. She's on simvastatin, captopril, and ibuprofen. When she comes to see you, she has jaundiced eyes and skin. Her conjunctiva are pale. She has some shoddy lymph nodes, and her spleen is palpable. You can feel her spleen. So what are you thinking in this patient?
Hemolysis.
Why do you think? So someone mentioned hemolysis. What makes you think of hemolysis?
The dark urine, the jaundice, palpable spleen.
Good. So the dark urine, the jaundice, the skin, and she has pale conjunctiva, so you think she's anemic. So good. So we think of hemolysis, and with hemolysis we get certain labs as we discussed before. So haptoglobin, LDH, indirect bilirubin, and then sometimes we can get what's called a direct Coombs test, which is an antibody test to assess the presence of antibodies that are coating the red blood cells to see if there's an attack on those red blood cells. So it's a sort of a body's own reaction to the red blood cells. And so in this patient, she's quite anemic. Her hematocrit is only 17%. Her MCV is elevated. Her white blood cell count is normal with a normal differential. Her platelet count is normal. Her kidney function is okay. She's spilling some bilirubin in her urine. She gets a troponin, which was elevated, and they did a type and cross antibody screen, which is this direct antibody test. And so her reticulocyte count, when they calculate it, is now 10%, or corrected, it's 4%, which is still high. So she's hyperproliferating, suggesting that the ingredients she needs for her marrow are working. Her platelets and white blood cell count are normal. And so we spoke about the additional tests we need. We're going to get a direct Coombs test, an LDH, a bilirubin, and a haptoglobin. And the direct Coombs test helps to decide if the hemolysis is because of the body's immunity or if is something in the body, aside from the immune system, breaking down the cells. So sometimes patients with a heart valve, it can cause sort of shear stress into the red blood cells, and that can cut the red blood cells. Or if the membrane itself of the red blood cell is weak or damaged, it can cause hemolysis. So, but those are not immune regulated. So we first test this direct antibody test, or the Coombs test, and one of the first steps in this algorithm is to check if it's negative or positive. If it's negative, we check if it's an extrinsic red blood cell defect, so is it the vessel, the valve, or a toxin that's causing it, or if it's intrinsic to the red blood cell, so the membrane, the hemoglobin disorder, or the cytoplasm. If it's positive, if it's an autoimmune process, we check if it's a warm antibody, such as IgG, or a cold agglutinin, like a complement-mediated process that's attacking the system. And these are the kinds of cells, you can see these fragmented cells that are causing the disorder. And this is called fragmentation hemolysis, and this can be a medical emergency. These are just some pictures of hemolytic cells. And so, again, the warm type is IgG typically. We don't know the cause of it in 60%, but secondary causes are lymphoproliferative disorders like lymphoma, certain drugs, other cancers, and bone marrow transplantation or other types of transplant, which the body thinks that the cells are foreign. And the cold type, there's a lot of overlap, but things that you should, in addition, think of, which are more specific to the cold type, or IgM, are infections with mycoplasma or mono. The treatment for autoimmune hemolysis can be prednisone, steroids, medications really to stop the immune system from working so aggressively. And it's important to give them folate because, as we mentioned, folate is necessary for the release of new blood cells to work properly. And because of hemolysis, the body really does a very vigorous response to the hemolysis. And you want to make sure it has all the building blocks necessary. The cold type, we want to avoid the cold. That's where these it aggregates in the cold temperatures, so less than body temperature. Sometimes we take out, if it's too aggressive, we do plasmapheresis or other chemotherapy. But splenectomy and steroids are not helpful for the cold type. So we spoke about this. Again, extravascular versus intravascular. The ones that are really something that we have to do things emergently for are DIC, or disseminated intravascular coagulation, or TTP, or if there's a valve, or potentially sepsis. And the characteristic organism that can cause intravascular hemolysis is Clostridium, and that can cause a life-threatening infection. So the take-home points are: we suspect autoimmune hemolysis with an acute presentation. We do the direct Coombs test to check for the presence of the warm antibody or a cold antibody. If it's a warm antibody, we give them medications to suppress the immune system. For cold antibodies, those are not that helpful. Think about also infections like mycoplasma and mono. And there are a host of non-immune causes of hemolysis. We'll skip this case. So case 4, it's a 30-year-old woman who needs an employment physical exam. She doesn't have any complaints. She's G2, P2, and a recent immigrant from Thailand. The only medication she takes is occasional Tylenol. She's mildly obese and no enlarged lymph nodes. Her thyroid's okay. Her spleen and liver are okay. Her hemoglobin is slightly low at 11.8, just moderately low. Her hematocrit is 35, and her MCV is 68, so microcytotic. And her white blood cells, the differential and the platelet count are all normal. And so how do you work up this anemia? So the first thing, again, we want to look at is the reticulocyte response and then the size of the cells. And so they looked at her reticulocyte count, and when they corrected it, it was only 1.5%. This picture, actually, unlike the other ones, it shows a lymphocyte, and so the red blood cells should be the size of this. And you can see they're a bit smaller. So she has a microcytosis. They did iron studies, which is common things being common. Iron deficiency is the most common cause of a microcytosis, but her iron level was normal, her binding capacity was normal, her ferritin was normal, and her transferrin saturation were normal, making the diagnosis of iron deficiency less common. So the next steps, and again, this patient was from Thailand, and in Southeast Asia, and I'll show a map, there's a condition that is quite common in those areas that lead to a microcytosis. And that's disorders of hemoglobin or thalassemias. And this belt here, so this, in the green here, I'm sorry, in the green is this belt in sub-Saharan Africa is sickle cell anemia. That is, really we see primarily in areas where there was a high malaria burden. Patients who have sickle cell trait are somewhat protected from malaria. This belt here, which is a longer belt that covers northern Africa and the Indian subcontinent and Southeast Asia, is thalassemia. And so this patient was from Thailand. So normal hemoglobin production, it goes, as a fetus all the way to, adulthood, but the production of where it's synthesized varies. From the yolk sac to the liver to the spleen in fetal development to the bone marrow in adult development. And the normal adult hemoglobin is a tetramer composed of 2 alpha subunits, which are here, and 2 beta subunits that are here. And that creates a polymer. And when there's a abnormality in the synthesis of one or more of these chains, it leads to impaired hemoglobin production. This is just, so most of adult hemoglobin is hemoglobin A. We have some A2 and some fetal hemoglobin even as an adult. This is just a gel electrophoresis, which shows different phenotypes. And this, this is Bart's phenotype, and this actually is not compatible with life. The hemoglobin production is necessary for oxygen dissociation, and when there's not adequate, if hemoglobin is not in its proper conformation, it won't dissociate oxygen into the blood. So patients with mild disorders, whether it's alpha thalassemia or beta thalassemia, they typically are asymptomatic, and you don't have to really do much for those. You may not have to do anything for these patients. They may be okay. But patients with intermediate or severe disorders, they can be more problematic. In beta thalassemia major, they oftentimes will need lifelong transfusions, or potentially bone marrow transplantation if that's an option, if there's a match for those patients. And again, this just shows abnormal red blood cells, and this is just massive splenomegaly in a child with beta thalassemia. So we the take-home points for that is that we suspect thalassemia trait with mild anemia and significant microcytosis in common ethnic groups, especially patients from Southeast Asia. I work at Harborview, where we do have a large immigrant population, and it's not an uncommon cause of anemia among that population. We have to differentiate it from iron deficiency, as was done in this patient, because we don't want to just give iron to patients who are thalassemic, because it can create iron overload. The important point about thalassemia trait is, in addition to the patient, it's more the risk of passing on the gene to the child, which can cause, can lead to severe thalassemia if both parents have the trait, and that can be detrimental. So there are a couple more cases, but I think in the interest of time, they all have the slides? Mm-hmm. Yeah. So I think why don't we stop for a minute, and I'll take any questions first, both from the audience and audience here and remotely. Oh, sure.
You should be coming in right here.
Great.
Do you have questions here?
What is
Well-
the site of production of erythropoietin? Where is it produced?
In the kidney.
I'm gonna repeat.
Oh, sorry. Erythropoietin, where is it produced? It's produced in the kidney, and so sometimes patients who have end-stage renal disease may need the assistance of erythropoietin to help. And hepcidin, which is that master regulator protein for iron homeostasis, is produced in the liver.
Where is B12 stored?
Where is B12 stored?
I think you said we had a several years storage.
We do. So it would be stored, I think, in the enterocytes, but I'm not exactly sure where B12 is stored.
If you see someone who has like a mild, what do you think is iron deficiency anemia? In what populations are you comfortable just treating with iron, and in what populations do you need to immediately do more workup?
So the question was, in a patient with a mild iron deficiency or a mild iron deficiency anemia, what populations do you feel comfortable treating versus being more aggressive in the search? So it really depends on how close follow-up you can have with the patient. I think it's reasonable. I mean, I think that patients with a microcytosis who have a low reticulocyte count merit the testing for iron deficiency with the test that you had mentioned before. So we want to check a ferritin, we want to check iron, we want to check TIVC, because we don't want to confuse it with a thalassemia, which does show the same microcytosis and a hyperproliferative state with reticulocytes. Because again, giving patients with thalassemia iron can be detrimental. So that's really the main thing we wanted to separate.
Could you maybe say a little bit more about, there's been some discussions about the anemia in older adults and whether it's normal to have what we might call a mild anemia and whether you should really aggressively treat it?
So the question was in adults, and I'm sorry, I should have catered this a little more to a geriatric population. The question was in adults, what is the, in a patient who has a mild anemia, who's an elderly patient, how aggressive should we be with therapy? And it really depends on the patient. I mean, I think we have to look at symptoms. So I don't think just based on age we should not give the therapy. But if the patient is symptomatic, because iron deficiency by itself does have a lot of problems, especially in the elderly, especially cognitive disorders. So among children, there's been a clear association between academic performance, cognitive issues among children and the elderly. So patients who are iron deficient on both ends are more likely to have some kind of cognitive dysfunction. So I think it can be helpful. And the treatment really for iron deficiency is relatively benign. Now, sometimes we give patients, to take iron 2 or 3 times a day, and they may not tolerate it. So we're a little bit more flexible. Okay, start with a day, taking the pill daily. But I don't think just age by itself should to forego the use of iron therapy.
Okay, and they can hear me because I've got a microphone out there, but you see somebody was saying 60% of B12 is stored in the liver and 30% in the muscles.
Oh, thank you. Thank you. Any other questions?
Well, maybe you could talk a little bit about anemia of chronic disease, which we see in a lot of older adults.
Yeah, so that's probably a very common. I mean, it's probably 30% of cases of anemia are anemia of chronic disease. And anemia of chronic disease used to be called anemia of inflammation. And so it really probably is related to hepcidin. So in a patient who has any kind of inflammatory stimulus, the hepcidin level is increased, and as a result, it prevents the release of iron that we're taking in our body. So it will prevent the absorption of iron from our body into the plasma. And so really the most important thing is to treat the underlying disorder. Now, we can monitor how we're doing with other parameters that we look for as inflammatory markers. So ferritin would be increased, but so would C-reactive protein as one marker of inflammation. But the primary thing is to try to block the underlying cause, because in those patients, giving iron, for example, will not be of any benefit, and it could be detrimental. So the key is trying to find the underlying cause and treat appropriately.
In your practice, do you see a lot of people who are at risk for sickle cell trait or thalassemia or something like that doing genetic screening, and then do you see them making decisions based on that information a lot?
Yeah, so good question. So the question was regarding sickle cell or thalassemia, the role of genetic testing, and how that impairs decision making. So in my practice, trait is actually not typically something that I see, because in hematology clinic we typically wouldn't see patients with the trait because they're relatively asymptomatic. So the patients that I see either do have sickle cell anemia, which requires therapy, or beta thalassemia major, which requires therapy. But I do think it's important just for shared decision making. So if one partner knows that he or she has the trait, and as part of counseling, prenatal counseling, I think it's important to recognize what the issues are, because it really does affect therapy, and it's easier to catch these things. It's more important to catch these things earlier than later. And now there are, and I'm not as familiar because this is not, I'm an adult hematologist, but pediatricians, they really, post-birth, there's a lot of screening that they do to try to detect these traits earlier. But sickle cell is, and there's actually a slide I can just talk off the cuff regarding sickle cell. So it's a huge issue, and and you'll see a lot of patients in the hospital because of sickle cell anemia, in a disproportionate amount because of some of the sequelae of sickle cell. It can have a host of complications, and so just with sickle cell, the cells are sickle-shaped. They're not like oval or round-shaped cells. They're abnormally shaped, and so when they go through the vascular system, they don't flow in the same way as normal red blood cells do. And so it can cause a host of problems affecting the eyes. It can cause a retinopathy. It has pulmonary complications. It can cause avascular necrosis of bones, and it can cause pain crises. And those pain crises can be quite problematic, both, it can be debilitating. And oftentimes our patients require very close monitoring to make sure their pain is under control and their medications are under control. There's a question on sickle cell disease in our elderly patients. Any changes to note in our later years? So really, it's a great question. The therapy really for adults and for young adults and older adults is really the same, and the primary therapy that we use is a medication called hydroxyurea. that we monitor our patients with, but it's really the prevention of the sequela of sickle cell that we really have to pay a lot of attention to. So you want to make sure that patients are being followed, that they're getting their eyes screened to make sure there's no evidence of retinopathy, that their lungs are okay, that there's no pulmonary complications. And it's important for them, for all patients I think in general, but especially sickle cell patients, to have a really strong therapeutic relationship with their provider. Oftentimes these patients do have pain crises, and unfortunately oftentimes their pain, as is the case with many patients with chronic pain, their pain is discounted. And it's really important, I think, to have an established relationship with a care provider. And even if that means developing a written plan that says, this patient needs this, and this pain medication every so often in a very consistent fashion. And I think that's probably one of the best things that we can do to strengthen that relationship.
So we actually often hear about sickle cell patients in their, adolescent and younger, adult years. So are we seeing sickle cell patients in their older years, and are we learning some things about how the sequelae might change as they get older?
So I don't think this, so the question was regarding most of the times we hear about patients with sickle cell are children or young adults, and the lifespan of a patient is reduced with sickle cell compared to a patient without sickle cell. The complications are sort of cumulative, and so there's the sequela that we discussed in terms of avascular necrosis of the hip, the pulmonary complications, the retinopathy. Those all will increase over time, and so I think it's really important to have screening for all of these things. And so it's important for sickle cell patients to have regular visits with their eye doctors. Sometimes there's skin manifestations because there's not as good blood flow peripherally, and so they can get ulcers. So it's really important to just try to be on top of these things as we can. And it's okay, we're more permissive with the anemia, actually, the anemia aspect of sickle cell. We actually don't want it to be, the blood counts to be too high. We want to try to allow for it to be a little lower than normal. One of the folks in the field here mentioned that the average life expectancy for sickle cell is now in the mid-40s. So it's increased from what it was, but it's still lower than normal.
And thalassemia? Do we see much thalassemia in?
So do we see patients here with?
Mm-hmm.
Yeah, we do.
Older
especially
adults?
Yeah.
Okay.
Again, it's thalassemia. The treatment, what has to be careful, both with sickle cell and thalassemia, one of the main issues is iron overload. These patients require they potentially would require multiple transfusions, and so, iron again is a necessity for life, but you don't want to go on the other side. It can really cause damage to the heart, to the liver, and so it's iron overload is a concern for patients with thalassemia as well.
Other questions, folks?
I think someone's typing. It says.
See what Providence Valdez has to say. It's sort of embarrassing, but I just always think of sickle cell and thalassemia as not being an older adult.
It's not. I think that's a correct. So the question was, I don't think of sickle cell and thalassemia as being an older adult population, and so that's probably correct. It's not. It's definitely the lifespan of both are lower, and we definitely see many more younger and young adults, mid adults.
And so, again, drawing back on past, not my current area in gerontology, but I remember there's information about, for example, sickle cell, that people who are carriers versus manifest the trait. So do we see any problems in those people who maybe had a milder form but make it to their older adult years?
Yeah, so sickle cell trait, actually, the lifespan is very comparable to normal. It's the homozygous condition that's particularly debilitating. So there's a question about, would you recommend menstruating women to take iron supplements? And I don't think the recommendation routinely would be for all menstruating women to take iron supplementation. It's really if they're iron deficient to take it. Again, I should have shown a slide, and I didn't bring it here, but there's a nice illustration of this iron axis that you really have to be careful with too much iron and too little iron. So the empiric use of iron in a patient who has a normal iron level is not necessary. I think eating a balanced diet is fine to do it. And our body has a nice way of regulating the balance of iron. But in a menstruating woman, among menstruating women, I would think approximately 30% of menstruating women are iron deficient. And so in those women, it would be reasonable to take iron supplementation. But again, most people, men or women, are not that keen on on taking iron. It causes constipation and other GI side effects.
Okay, well, I think we're done.
Great.
Thank you very much.
Thank you. Thank you.